Good afternoon, friends. This is the story of a young person who was known to the hospital employee. He was brought to the hospital in the emergency room in a very significant complaint of chest pain. Classical signs and symptoms of acute MI. So he is a 45 years old young man admitted through the emergency room with classical signs and symptoms of acute MI like chest pain, sweating, shortness of breath. Blood pressure was borderline around 110/70, saturation was maintained. ECG, as I told you, was clear cut showing ST elevation in the anterior chest lead. The echo was hypokinetic anterior septum. Ejection fraction was 40%. The troponin was done and it was found to be positive. So everything was significantly suggesting that patient had sudden onset of chest pain, acute anterior wall MI. So this patient actually, after taking the history and making the diagnosis, he was immediately taken to the cath lab. Angiography was done and we found a very tight lesion in the LAD which was appeared to be very very easy to do, but we did not know and we that nothing is very light and very easy in the cath lab once you have taken the patient for the angioplasty or something. So the tight lesion in the LAD, the circumflex was normal. We can see in the mid LAD there is a tight lesion and immediately after that there is a diagonal which is coming out. So as usual the guide wire was passed through the lesion and ballooning was done. Everything was under control. Patient was asymptomatic, vitals were maintained. You can watch the contractility is also fine. So angioplasty as well as the stenting was done in the regular manner and the 13 millimeter stent lines was put across the lesion and that was immediately after putting the stent, and that was the final shot after before shifting the patient to the ICCU.
Your distal wire is never visible.
I'm sorry. The only thing was wire. You look at the wire, the only thing is the wire is slightly in the small vessel, distally in the LAD, it is slightly in the diagonal. So, which was, we did not worry about this one because the procedure was completely asymptomatic and uneventful by the time.
Something wrong there actually.
No, just listen. The patient was transferred to the CCU with this kind of the picture and we are very happy that the patient is known to the hospital employee and everything is fine and patient will be discharged tomorrow or day after. So with this kind of thing, the patient was sent to the ICCU and discharged after 2 days of regular angioplasty. But we did not know that nightmare has to come now. After 7 days, the patient came back again with a complaint of increasing shortness of breath, hypertension and tachypnea. The family people, they came and brought the patient, and when the patient reached to the hospital emergency room, he was in cardiogenic shock kind of situation. The pulse rate was tachycardic, the blood pressure was 80/50, the saturation was low and the respiration was on the higher side. So everything was telling us that something grave is happening, and since we have done the angioplasty on this patient, we thought obviously, this is a common philosophy that since we have done some procedure on a patient and the patient comes back to us within a week or so, obviously it is something procedure related problem we are dealing with. So immediately we thought that something came to my mind that obviously it is an instant thrombosis, subacute thrombosis of the stent. So immediately ECG was taken and ECG did not reveal very significant problem. There was a sinus tachycardia only and some resolving changes of anterior wall MI. Immediately the echo machine was brought to the emergency room that showed the moderate pericardial effusion all along with the early tamponade features. Immediate in the emergency room the tapping was done and the pigtail was inserted. The aspiration which was done was hemorrhagic in nature. So one thing was clear that ECG is normal except for the sinus tachycardia and the pericardial effusion and leading to tamponade was the cause of this problem, and this one was hemorrhagic in nature. So with this kind of finding, we had taken this patient back to the cath lab immediately and we thought there might be a perforation. Once the subacute thrombosis was ruled out, the next thing which came to my mind was obviously there some perforation would have taken place. We retrieved the angiographic film of the patient and we saw what Dr. Raman Chawla has pointed out very clearly, that patient had wire in the small vessel that was in diagonal. So next thing which came to my mind was obviously it is a perforation because this is causing the pericardial effusion and tamponade. The angiography was done immediately and you can see in this film the pigtail catheter is already in the pericardial sac. The contractility is already down. This is after aspiration of 250 cc of hemorrhagic fluid. So the patient had a lot of contractility problem, hypotension. But shockingly, pericardial vessels were all normal. Epicardial vessels are all normal. There is nothing which suggested that patient has perforation in the coronary artery. The LAD was normal. The twig in which the wire was there is also normal. The circumflex is also normal. So, I mean, we have taken a couple of shots of the coronary that we thought something we are missing somewhere. Nothing could be found. Then we thought might be right coronary artery because we had taken a diagnostic shot in the right coronary artery. We have done something wrong in the right coronary artery or not. So we have taken a diagnostic shot in the right coronary artery. But unfortunately, nothing was found. And we are surprising. उसके बाद मेरे दिमाग की बत्ती जली, Mentos खाया. Then we thought that we should do LV angiogram. And this LV angiogram actually decided and solved my problem completely. This LV angiogram, you can see it is filling the right ventricle also. You can make out? I mean, this LV angiogram was done in the LV view. It is not only filling the LV completely, it is filling the right ventricle also. So, I mean, immediately the diagnosis was made that patient has got a tear in the myocardium and patient was immediately sent for the surgery. Fortunately, the surgeons were free that time. The OT was also free. There was a rent in the LV near the apex and it was repaired and the post-operative period was uneventful except for hypertension persisted for 1 or 2 days and patient recovered and the patient was sent home in a stable condition. 6-month follow-up of this patient was also nothing eventful. So the friends, the take-home message after this episode, finishing PTCA successfully is not the end of the story. You have done the angioplasty on a patient. You are the responsible person and you have to take all the responsibility. Your job is not completed unless the patient is completely fine, especially in a 1 week or 2 week time after the surgery or after the angioplasty. So finishing PTCA successfully is not the end of the story. Subacute complications do happen and should be treated with a great caution. Sometimes complications do look like procedure related. What I thought, it might be a perforation, coronary perforation, it might be instant thrombosis. Sometimes they do look like procedure related complications, but they are not. Use of little extra gray matter might be useful in solving the problem. Thank you very much.